Nigeria chapter. And in this year, 2024, we are starting our activities. And we are starting with the topic Airway management by Mr. Adedeji, Emmanuel. So it is nice for us to gather here again, because last year we really did a great work and a great job. Last year we treated a lot of topics: policy and guidelines in perioperative practice, abdominal incision, sutures, techniques, and nature and materials, a lot of topics. So this year, we are starting with airway management. So before we move to our main topic, I would like the president of the operating room global, that's Mr. Adedeji, to give us an opening charge to also educate our audience about the operating room global, what the operating room global stands for, in just a minute or 2 minutes before we start the activity properly. So, Mr. Adedeji, please, can you hear me?
Yes, I can.
Thank you very much, ma'am. Over to you, ma'am.
Yeah, thank you so much, everyone, for joining us. It's the beginning of the year. Apologies, I couldn't turn on my video because of my location. I want to welcome everyone to this first webinar of the year by the TORG Nigeria chapter. And I want to really appreciate the leadership of the chapter and everyone represented in the chapter as well. In a nutshell, as has been said, the Operating Room Global is a platform for all operating theater users or professionals in the operating room environment: nurses, surgeons, surgical technologists, perfusionists, about almost 17 professionals represented in the operating room environment. It's like a multidisciplinary platform. The Operating Room Global is a network. So we deal with knowledge sharing, collaboration, innovations, research. TORG is not a trade union, so we wouldn't deal with salary stuff or negotiating maybe better opportunities for countries, because there are existing organizations at that end, and we are like a synergy of organizations, and basically we have an international focus. So that's about the Operating Room Global in a nutshell. It was founded in 2015, and the Nigeria chapter happens to be the foundation chapter. It's the founding chapter of the organization. We started in Nigeria with about 8 members. That was in 2015. And when we went online, basically the background then was, personally, I wanted to go to another country. I wanted to travel to another country. And, you know, like when you try to look for opportunities outside your own country, and then you go online to try to find someone to put you in the right direction, you want to know if this country is going to be okay, if Canada is going to be okay, if UK is the option, or if US is the option, for example. And unfortunately, at that very year, there was no single platform online where you can actually meet with other professionals in the same operating room environment, because you are specialized in that field, that can point you in the right direction. So that was the background of how the organization began. We started in Nigeria, and when it went online, we started seeing this significant interest from other countries that they want to become a part of the organization. So it was founded in Nigeria, and currently we have about 22 chapters, and we have membership from over 80 countries, about 89 countries in total. And generally across the platforms, we have over 100,000 now operating room professionals connected in TORG. So have focus basically is on knowledge sharing. We want to bring what's obtainable in the outside world, in the modern world, to people in the comfort of their homes. There is power in networking, there is power in collaboration. And in TORG, you can meet with people that even in the next 10 years, one would literally think that, oh, there's no way I could be connected to this person in another 10 years because of the level of relationship or because of the professional, your status in the society. Or TORG would actually give you that leverage. We close that gap and bridge that and connect you with like-minded professionals, people that would motivate you and give you the focus that you need and keep pushing you forward, if you understand what I mean. So that is that about TORG in the nutshell. I want to welcome everyone to this webinar, first of its kind in this year. And I want to appreciate the leadership for the opportunity given to me to talk about TORG. Thank you so much, everyone.
Thank you very much, Ma. Thank you very much, Ma. You're welcome. And I also want to thank you for the initiative of TORG, because I want to say you're a visionary leader. Keep it up, Ma.
Thank you.
We are really, really proud of you. So,
thanks a million.
The business of the day, Airway Management, the first of its kind this year, the Operating Room Global Nigeria chapter presentation. I will be calling on our speaker, Mr. Adedeji Emmanuel. He is the Vice Chairperson of the Operating Room Global Nigeria chapter. So, Mr. Adedeji Emmanuel, over to you, sir. Thank you very much.
Okay. Good evening, everybody. I don't know what is the time at Republic of Ireland now, but 8 o'clock in the evening in Nigeria, and as many other people are joining us from other country, good morning, good afternoon, good evening. Thank you, Mr. Additional, for the opportunity to do this presentation. I want to request, I hope this is recorded.
Yes, it is. I think it's been broadcasted live on YouTube. I'm just trying to check to see, and it's recorded as well. So, yeah.
Okay, thank you. I appreciate it. Okay,
Thank you,
because
sir.
a lot of work went into this. So, anyway, so yeah, as much as I try to put so much things together, you know, medical science cannot be exhausted. So, so based on your experiences, you might have one or two things to contribute after the presentation. All ideas are welcome. I'll try within the shortest time to share the little things I put together, and I want to believe that it's going to be worth our time and our evening time. Permit me. I was trying to use my laptop, but I'm getting some difficulty. So I'm going to be presenting on my phone. So should there be any challenges, please don't hesitate to put me in the chat box so that I can adjust. All right. So let me share my presentation. All right. Sorry, just give me a few minutes. Sorry, just please give me a few minutes. I didn't know if you said. I'm sorry. Okay. I'm trying to share. I'm not used to sharing from the phone. But please pardon me. I'll get over it now. Just give me a few minutes. I'll soon get over it. Okay, let me see if I can be presenting from my without sharing it first. So let me see if my system come up, then I'll share from the system. Meanwhile, I can present from here. Sorry. Okay, I'm trying to share, but let me start presentation from here. As soon as I'll be trying to figure it out. Actually, so the presentation is on Airway management, and I'm starting with basically on what is the significance of Airway. Why are we talking about Airway? Airway is the significance of Airway in the management of patients. What I put here is a part. I simply put it as a pathway for exchange of gas. And in the exchange of gas, basically, it's talking about CO2 and oxygen. However, by secondary, so we said, okay, so anatomically, airway is divided into upper and lower airway. And airway divided to upper and lower airway. And in terms of airway, we also I've told us about the chief function of the airway in clinical science is basically on exchange of gas. We all know, like I said, CO2 and O2. Then structurally, we're looking at, I put it here as ventilation perfusion match. Now, when we're talking about airway, we're looking at the relationship between ventilation and perfusion. And what does that mean to us? It means that before you can achieve ventilation, it means that there must be perfusion, adequate perfusion. So structurally, we said that we have the anatomical dead space and we have the physiological dead space. And then, of course, what do I mean by anatomical dead space? We have some part of the airway that is basically, we call them anatomical dead space. And what do I mean by anatomical dead space? If you can picture the anatomical diagram of airway, you agree with me. You agree with me that you can just picture the airway. You will see we have the from the mouth to the pharynx, and then, of course, to larynx. Before we talk about the epiglottis, the glottis, the trachea, and of course, those are the structures that we can call the upper airway division. So these upper airway divisions, like I've mentioned, we have the mouth, we have the, of course, the mouth, the nose. Then beyond that, we have the pharynx, we have the larynx. Then, of course, the pharynx is divided into three. We have the oropharynx, we have the nasopharynx, and then of course we have the laryngopharynx. So these three structures, these three structures are identified as the upper airway division. Now, this upper airway division does not participate in respiration. This upper airway division does not participate in respiration, and that's why we call it anatomical dead space. That's just a channel where air passes through. It does not take part in cellular respiration. Does not take part in respiration. It only serves as a channel for respiration to take place. So because of that, we call it. It is called anatomical dead space. Dead space means something that does not. It does not perform any function, physiological function, than just a pathway. Now we have the physiological dead space. Now, in a situation where part of the respiratory system that's supposed to participate in the respiration fail to do so, we call it physiological dead space. And what does that mean? So that means that even in disease condition, for example, when the lung is supposed to do the work of exchange of gas, but refuse to do it. So we said we call it physiological dead space. Now, what do we call shunting? Shunting is, okay, so now the area of the body that is supplied, the area of the lung that is supplied with blood. Okay, so I think I'm coming up. Yes.
Recording in progress.
Okay, so let me share for my assistant. Please confirm if you can see my screen. Please confirm.
Yes, you can see the screen.
All right, thank you. Okay, so as I was saying, physiological dead space is a space between the dead space and what is the difference between dead space and shunt? Okay, so the dead space can be referred to a part of the respiratory system that does not participate in the respiration, in the exchange of gas, meaning that there's no exchange of gas at that level. There's no blood supply, naturally, anatomically. Now, there's a part of the body that is supplied with blood for exchange of gas, but exchange of gas does not take place there. So this part of the body, is called shunting. Now, so so let me just put it out. I will explain it as I go on in the conversation. Now, I put it as structural components and of course the cellular component of the respiration. This talks about oxygen. We call it oxygen dissociation curve. The buffer system in the body. For some of us, I don't want to bore with all of these things. There's still many things to talk about. There's a buffer, of course, the buffer system, which speaks to the lung and of course the kidney. And then what do I mean by that? If you look at this formula, I don't know if any of us are familiar with this formula. This is more or less like a chemistry class formula. The C6H12O2 plus O2 is equal to CO2 plus water. Now, C6H12, how many of us know what CHO? What does it mean?
Glucose.
Thank you very much. So CH, this is the formula for glucose. So with the addition of oxygen, you have the carbon dioxide and the oxygen. So what that means is that the oxygen participates in the function of oxygen at the cellular level. It breaks down glucose molecule, so it can give off oxygen and then of course produce water and you know that our body system is made up of about 70% of water. And then of course the CO2 come out from the lung. We get the O2 from the lung and CO2 come out of the lung, because it's not used in the system. Of course, the excess water is also released from the kidney. And these two functions perform the works of maintaining the acid-base balance in our body. If you know, I don't know many of us know this formula. If this CO2 plus O2, combined together, in excess, also form another compound called carbonic acid or something. So if it continues to stay in the body, it can result into acidosis or acidemia, so to speak. So that's why the functions of the lung and the kidney becomes relevant, because excess of all of these things, excess of CO2 in the body is taken care of by the lung, and excess of water in the body is taken care of by the kidney. Of course, so O2 is also catalyzes synthesis of adenophosphates, which is the ATP, the energy source in the body. However, so it also drives energy dependent process in the body. We've talked about catalysis. Catalyst is something that speeds up the process, the metabolic process in the body. So basically what oxygen does is aid the activities of metabolism, metabolism in the body. So that's why in the absence of oxygen, sometimes some of these things come, so it's become, that's when you see pushing anaerobic, so call it aerobic metabolism or an aerobic respiration, aerobic or anaerobic metabolism. So in the absence of oxygen, the body will still break down, but the end result will result into acidosis. So that's basically what it is. I'm thinking about bicarbonate plus CO2 resulting in carbonic acid. All right, okay, so next slide is talking about okay. Sorry, please confirm if you can see my next slide.
Yes, you can see it.
All right, okay, thank you very much. So as you can see, you see the structure. I tried to put together the structure. On the far left is the gross picture. At the other side is the more how will I call it now, microscopic structure, if there's anything. Okay, yeah, more or less like this is on the far left is more of gross structure, and on the far right is more of a microscopic structure. So, and then of course you can see if you see the exchange of gas at the alveoli. Alveoli is the last of the respiratory tree, and that is where the exchange of gas takes place with the capillary. So the CO2 is released from the body, from the blood, and then of course oxygen is returned to the blood through pressure gradient. So basically, I'm sure we're all familiar with all these structures. Just a reminder of what we're already used to. So yeah, so more detail here. As you can see, the another dimension of the lateral view. You can see the epiglottis. You can see the epiglottis. You can see the thyroid ligament. And the anterior neck structures, thyroid cartilage, cricoid cartilage, trachea ring, you know, and of course, this is the anterior, this is the posterior part, the epiglottis, the vocal cord. You know, we can see the thyroid cartilage on the lateral side. You can see the cricoid cartilage also, and also we can also see the trachea cartilage. So, these are some of it. So this is we call it windpipe. This is the if air goes in from either from the mouth or from the nose, it goes through this structure, and then of course all the way into the lung, here. And then of course the end point is the alveoli. The alveoli here broken down here. Now you can see this structure. Ignore you don't necessarily. So of course you can see the trachea ring from C1 to C7 and T1. So this is also relevant in the further conversation. So this place is the base of the tongue, and then at the base of the tongue. So if you look at if patient is lying supine, and then you try to scope the trachea, so the tongue is anterior. The tongue is anterior. The base of the tongue forms the roof of the vocal cord. The base of the tongue forms the root of the vocal cord, and then at the base of the vocal cord is the esophageal orifice. That's the opening of the mouth. So, as a nurse anesthetist, this particular structure is so important to me. This groove, we call it vallicular. You know, the vallicular, the epiglottis, and of course all the other ligaments that supports the vocal cord. All these ones are the ones that hold. As I'm talking now, all these things are working interchangeably to sustain voice and also at the same time allow me to breathe. So these are relevant to us as professionals when it comes to airway management. All right. So the next point is talking about the nervous and the vascular supply to the airway. The major nerve supply to the airway is vagus nerve, and vagus nerve is of course airway is supplied by autonomic nervous system, and from the autonomic nervous system we have the parasympathetic and the sympathetic nerve. So the sympathetic nerve that's the parasympathetic nerve. The major parasympathetic nerve in the body is the vagus nerve, and which runs from the larynx all the way down to the lower part of the body. So now, of course, lower part of the body in the trunk. Now, and the smooth muscles. Now, the vagus nerve in the airway, the upper airway, we have the superior laryngeal nerve and the recurrent laryngeal nerve. And of course, we have the vascular supply. We have the internal jugular and the external jugular from the branch of the common carotid artery. Okay, so now all these structures are important to us because they have their clinical importance. For example, for the superior laryngeal nerve, for the vagus nerve, for example, you see, if you want to try and put your hand inside your mouth, you notice that you will feel this flat and fright. You see your body respond in such a way to fight or to fright. So, and that's, if you remember the body response to stress, is very important. So that that's why most time before we put anything to a patient's airway, we want to ensure that patient is well relaxed. Otherwise, you might trigger there's something called a vasovagal reaction, because the vagus nerve that supply the airway also is the branch of that vagus nerve that also supply the heart. So there will be a bradycardic effect on the heart, and body patient will be scared. Clinically, patient can be scared when you try to stick anything to their airway when their muscles and all the nerves are not attenuated or they are not relaxed. So the jugular vein, I don't know if we are familiar. Of course, we know the structure, the location of the internal jugular vein, internal carotid artery. Carotid artery. Carotid artery supply the blood and run through the neck and up to the brain. And of course, like I said, they are the branch of subclavian artery from the aorta. Now, that's why we advise that when you are palpating the carotid artery, don't palpate the two sides at the same time so that you don't destroy the blood supply to the brain. Yeah, so all these things, like I said, they have their clinical importance, you know, even though they are academic, anatomy academics, but then they have their clinical relevance. All right, okay, so going to pure clinical, we've left the classroom, so let's go to what we see on a daily basis. So the question is, how do we identify patients with airway obstruction? You know, I put it that for patients who are conscious and the one that are unconscious. Now, for patient who is conscious, how do we know that this patient is in respiratory distress, or his airway is blocked, or he needs help, or this thing that we just described in the previous slide is no more patent, you know, that this patient is having problem. One of the things that you notice is sometimes you notice that patients might be restless. You might just be in a party. You might be in a party, might be in a restaurant, or you can be in the public transport, or you can be anywhere. You might be at a picnic. I just noticed that this person become restless, is sweating, look confused, you know, might be staring at you, you know, might be staring at you, and you notice that the person is restless, or he's coughing violently, or he might even be showing some choking sign. You know, choking sign is wrapping your hand around your neck. So patient might even be showing some sign of, you know, choking sign or gagging, you know. So these are things that you can see in the patient that is conscious and is in respiratory airway obstruction. In some occasion, because of the level of hypoxia or CO2 in the patient, the vomiting center can be irritated and patient can retch or vomit, actual vomiting. Then, of course, you know that at the point where patient vomit, that's another danger, you know, in waiting, because in that same patient can vomit and also get drowned in his own vomitors. Patient can aspirate. So, of course, and if you know, the breathing can become so noisy and wheezy that you can even hear it without putting a stethoscope in. I'm talking about, you know, probably outdoor or indoor, or even on the patient is on the bed. Maybe the patient is already being planned for discharge and is already ambulating and all of that, which of course happens a lot, especially in the pulmonary venous thromboembolism. You know, patients probably have been confined to bed, is not on any prophylactic thrombolytic agent, and patient just move and the thrombosis just mobilized and block the lung and all of that. So these are likely events, clinical events. Patient can go into difficulty in breathing. You know, patient, before you know it, patient can storm. If you watch closely, you notice that patient turn blue. You know, the next thing, it can become more responsive. So these are likely events. Now, in an unconscious patient, this patient is already unconscious, and in most cases, this kind of patient probably in ICU, a post-op patient, immediate post-op patient, has not yet post-anesthesia patient is not yet fully awake from the effect of anesthesia. How do you identify that this patient's airway is already obstructed or is blocked or something, either partially or totally obstructed? The patient becomes sweaty. And of course, in most cases, patient, of course, I mentioned, can be sweating, become cyanotic, that's bluish coloration. It can become tachycardic. At the initial response time, when there's a body autoregulatory function that responds to stress, and it responds with tachycardia. But when there's no help, become bradycardic. The same thing with tachypnea. People can be hyperventilating to flush out the CO2. But when the help is not coming, it becomes tired of, you know, hyperventilating, and it can go into bradypnea. So, and cold clammy skin is a sign of shock. Patients that is already going down. And then, of course, if you're in a center where you have CO2 monitoring devices like capnograph, you know, ethanol CO2 can become high. It can be increasingly high. The normal value is between 35 to 45 centimeters in water. You know, anything that is going above 45 is already a sign that this patient is already retaining CO2 as a result of obstruction in the airway. Now, what are the causes of airway obstruction? You know, like I've mentioned, I've divided into upper airway and lower airway. Now, in upper airway obstruction, that is anything from nose, mouth, pharynx, larynx, trachea, and up to the ileus of the bifurcation of the two lung. Patients there could be aspiration from secretion. Patients are just coming out of surgery, suctioning. Maybe patient is not properly suctioned. Patient has not fully come out of the effect of anesthesia. Is still neither here nor there. Patient is in pain. You know, pain can splint the diaphragm. If patient is in pain and maybe there is a chest surgery or close to the chest surgery, maybe an upper midline incision that is close to the diaphragm, patient will not be able to breathe very well into the abdomen so that it can allow for very large expansion of the lung. In that kind of situation, patient can become of course, there will be hypoventilation, and then the CO2 that's supposed to be flushed out through negative pressure. Of course, the pressure will drop because there's no enough space to accommodate tidal volume. So, a patient that has been on opioid analgesic has a central respiratory depressant effect on the brain, and then, of course, the respiratory center in the brain. Laryngospasm. You know, patients that it occurs a lot in a patient who is just coming out of anesthesia and maybe is not fully awake. You know, it's advocated that for such patients you're supposed to wake them fully awake or fully deep with oropharyngeal devices, with airway devices. So in this kind of situation, or you stick something to the patient's airway that triggers a spasm of the laryngeal muscles. So this can happen. There could be accidental injection of foreign body, either denture, fish bone, or food particle, or blood secretions or anything. There could be an infection, maybe like laryngeal edema, or laryngitis, or there's something called croup. There's this one called the inflammation of the airway. There could be hyperactive airway, you know. There could be hemorrhage. The patient might be bleeding. Might be the point where maybe they did a surgery, a laryngeal surgery or whatever, or tracheal surgery. The patient might be bleeding into the airway. There could be edema either of the blood vessels or of the tissue, angioedema, or the tissue edema. There could be iatrogenic cause, maybe from the surgical instrumentation. Maybe the patient has bronchoscopy done, or maybe has a laryngoscopy. In the process, there's a tracheal edema, and of course, is reduced the internal diameter of the trachea. There could be direct trauma, and there could be inhalational injury, or what we call motor neuron disease, which could paralyze the whole entire airway, the muscles of the airway. There could be emphysema. It's a very common complication with central line. Maybe you do a central line on the neck, or there's a tracheostomy, with tracheostomy too as well. Now, for the lower airway obstruction, I don't know if you have come across any of these ones before. It could be as little as venous thromboembolism events, which I mean pulmonary embolism. Patient could throw embolus into the lung tissue, or blood vessels and all of that. There could be pulmonary edema, which could be from heart failure. There could be asthma. There could be hypersensitivity reaction. That this Stevens-Johnson syndrome, I don't know, I've seen this before. The situation where a patient is reacting to HIV PEP drug, post-exposure prophylaxis drug, and all the mucous membrane, you know, were peeling off. All the airway mucous membrane were peeling off, and patients, you know, went into respiratory arrest. There could be heart failure, complete cardiac failure, which could be have a pulmonary effect, congestion effect. There could be traumatic acute lung injury. There could be interstitial lung disease. There could be acute respiratory distress syndrome. There could be COPD, chronic obstructive pulmonary disease. There could be tension pneumothorax. There could be tension pneumothorax from direct injury, direct or indirect injury, sharp or blunt injury. There could be pneumonitis, either from aspiration, either as a result of edema, maybe pneumonitis. bronchitis. There could be mechanical pneumonitis as a result of mechanical. Maybe there's an abrasion, or maybe there's any direct injury to the lung that causes pneumonitis. There could be pleural effusion in the extrapulmonary space in the pleural cavity. There could be pulmonary TB. There could be, I don't mean to put these terms. Transcutaneous, is the same thing as Stevens-Johnson syndrome, I mean to write. There could be central nervous disease from cerebral brain tumor, where the respiratory center is located, or traumatic brain injury, which will cause concussion, contusion, subdural hematoma. There could be spinal cord injury. There could be localized phrenic nerve injury, and there could be empyema. There could be metabolic changes from acid, maybe resulting to acidemia, especially in decay, diabetes ketoacidosis. So these are some of the things that could cause either systemic effects or localized effect in the lung. Now, how do we assess the airway? Airway assessment, shouldn't take a long time. I wrote it quick and focused assessment, which is 3 short minutes, not 3 long minutes. The 3 minutes is so short, even though 3 minutes is 60 seconds multiplied by 3. But in assessment of airway, because you have a limited time, you do it as quickly as you can and make immediate and early diagnosis help in approaching and managing the patient. Otherwise, patient can go into unconsciousness and can probably go into vegetative brainstem injury or hypoxic ischemic encephalopathy. So you don't want patient to develop the complication from the lung hypoxia. So immediate assessment can help, and then can help the patient to relieve. So patency is the next thing I was going to talk about. Patency speaks to a lot of things, which I'm talking about. You want to ensure, is the airway patent? Because there's no other thing you want to do if the airway is not patent. First of all, be sure that the airway of this patient is patent. Try and assess the breathing pattern. And then, of course, know if the patient is becoming cyanotic, and every other sign I've mentioned under the signs and symptoms of airway. Now, what are the airway management? We have the prompt diagnosis, like I've mentioned. Quickly identify the cause. If possible, you can. Otherwise, clear the airway if you can see it. If you ask the patient to open their mouth, if they can respond to call or to command. Otherwise, there's something we call triple maneuver. If the patient is conscious, you can do Emlich maneuver. If there's a foreign object obstructing the airway beyond the reach of the finger. However, if you can see the foreign object and you can use your finger to sweep it out, you can go ahead. Otherwise, Emlich maneuver can help for patient that's not yet unconscious. However, for unconscious patients, sometimes intubation, of course, advanced airway can help. Positioning is very important, key, especially for nurses, because our nurses are always with the patient. Apart from clearing the airway, the next thing you want to do is to ensure that the patient is in the right position. And then, of course, like I put it here, is to relieve, if you can maintain between 45 degrees to 90 degrees, depending on the one that is convenient to the patient, even up to the cardiac position. Now, cardiac position is when the patient is lying over the bed table, for them to be able to breathe well. All of this is to relieve the pressure on the diaphragm, so that the diaphragm can expand and can accommodate more volume of air, so that can help in the lung expansion, so that to avoid lung collapse at electrolysis. Now, triple maneuver can help in the patient that is might be unconscious, and this is chin lift, neck extension, and jaw thrust. It's a 3 maneuver that you are doing at the same time. You are doing you open the patient, and all of this is to open the patient's mouth and prevent the tongue from falling back, because patient tongue itself can be a reason why the patient's airway is obstructed. If the patient has motor neuron disorder, or there is maybe medication interventional procedures that warrant you to sedate the patient so deeply that the tongue muscles are now relaxed and they can fall back. So this can help the patient. Chin lift. You try and lift the chin of the patient, neck extension, and jaw thrust. Well, this position can be very helpful. If you know under BLS, maybe for some other discussion, we can talk in details and describe the position better. I'm sorry I didn't put it here. I was supposed to put it here so that we can see better, but you can check triple maneuver. There's a groove on both sides of the head. There's a groove. The patient is lying down. There's a groove at the junction of the mandible and temporal bone. That groove can take a little finger, and the little finger should go in there to displace the jaw. And this in itself can, prevent the tongue from falling back. So you raise the chin, extend the neck, and do a jaw thrust. With a C, they're using our hand, we call it C and E. I'm sorry I couldn't describe it. Maybe subsequent class, subsequent meeting, we can talk about it. Airway with C-spine stabilization with cervical neck collar in a suspected vertebral injury. So in a patient that we suspect to be having C-spine injury, it's important that we take into consideration the essential, because we don't want to cause a permanent damage to the spinal cord or to the spinal nerves and all of that. So before you do any triple maneuver, ensure that you have put, especially if you suspect that patient might be suffering from, and then patient cannot move the hand or cannot move the leg at that time. C-spine, a cervical neck collar, or in a low resource area, it's advocated that you do a Dunlop. Just ensure that the chin is in the same alignment with the nose, like a straight line, so that the jaw is not flexed. The mandible is not flexed, but it's extended. Not hyper-extended, but should be extended at a 180 degree, a plane degree. All right, so, and this is just to ensure that there's no secondary vertebral injury that will totally lead to complete spinal cord dissection. All right, okay, so I think this is my last point. Apart from basic airway management, there's an advanced airway management. And then, of course, this has to do, after we have done all of these things, of course, bronchodilators, this of course has to be under strict guidelines. Nebulization with saline or with cysteine derivatives, some use bicarbonate, and then normal saline toileting, especially in the patient that is in intensive care unit that is on intubation or oropharyngeal airway. So there are bronchodilators, we have beta agonists, anticholinergic, and theophylline, or others are corticosteroid, methylxanthine, leukotrienes, and leukotrienes modifiers. Of course, the aminophylines, the theophylines, the ipratropium bromide, the glycopyrrolate. These are some of the medications that can also help. However, the essence of ensuring there's a patent airway is for oxygen, proper exchange of gas from the upper to the lower airway. So we say that there must be oxygen and there must be means of delivery of that oxygen. And then, of course, you can give oxygen from low flow to high flow. Of course, we have here with the aid of the airway devices. We have the airway device. We have the nasal cannula. We have the face mask. We have the non-repeating face mask. We have the venturi mask. We have the bidet mask. We have the oropharyngeal airway. We have the oropharyngeal airway. We have the nasopharyngeal airway. We have the laryngeal mask airway. We call them supraglottic airway devices, and LMA and iGel. We have iGel. All these things has been used over time, even to the point of anesthesia. The whole essence is to access, the trachea so that oxygen can be delivered to the patient. And then in some situations where we realize that there could be some obstruction, you can, put the patient to sleep paralyzed. Try and see if you can view the airway within a very short test time, and then if possible, you can, put a tube inside. You can put a tube through the endotrachea or through the nasotrachea, or you can do a cricothyrotomy or tracheostomy. Then, of course, oxygen or without oxygen can be delivered either with or without pressure. We have the continuous positive airway pressure devices. We have the BiPAP, that's bi-level. We have the recent development, which is another idea. It's not recent. It's a new technology. Hello, I don't know if I think. Am I audible?
Yes, you are.
Okay. So I'm about to round up. So we have the last. We have the ECMO. That's extracorporeal membrane oxygenation. So this works like a dialysis machine. So it takes out the blood with CO2 and return with blood with O2. So in a situation where maybe patient has a primary lung disease, and you cannot do pressure ventilation, and you need to exchange gas. So you take out the whole blood. It works with the principle of dialysis. So you take out the whole CO2 blood and then return with O2 blood. And then lastly, this physiotherapy. We have under physiotherapy, we have what we call active cycle of breathing. That's ACBT, active cycle of breathing technique, in which we have patient to breathe in 10 times, hold the breath, and do like 2 puff, and then you repeat the cycle, and then chest therapy. Maybe you ask patient, you do the kind of chest tapping, to dislodge any secretions, any thick secretions in the lung. And then, of course, you can ask patient to do a cough exercise, hold their belly, and then cough out as strong as they can. And then, lastly, we have what we call incentive spirometry. You can ask them to blow to a spirometer. And then, of course, you can use that to encourage them to do a chest breathing exercise. Thank you very much for your attention. Thank you.
Wow. Thank you very much. Thank you very much. Thank you very much. Mr. Adedeji, Emmanuel, you really did justice to the topic tonight. Cecilia, I really learned a lot. Anatomy could get space, physiology could get space. I really learned a lot. Thank you very much. I don't know if any of our audience, I would like us to even appreciate our audience, even if it's just 1 minute. Let's just say thank you to Adedeji before we move to the WhatsApp platform for question and answer, contribution, addition, and respond just for open discussion. We can unmute ourselves and just say thank you. And we can also use the chat box too. I want to also use this opportunity to say shout out to our chairman, the Operating Room Global Nigeria chapter chairperson, in person of Mr. Abdulatif Adeyemi. We say thank you for joining us this meeting, and also everyone, say thank you for joining us in this meeting. Our chairperson, sir.
Good evening, sir. Samas. I want to use this time to appreciate everybody, and especially the presenter, Mr. Adedeji Emmanuel, for a well-presented paper. And I want to thank everybody for a good job you've been doing since all these days. I pray that Almighty God will continue to be with each and every one of us. And the Operating Room Global will go to places. And I appreciate your effort in educating and impacting knowledge to our colleagues and everyone that are using the operating room throughout the country and even beyond. Thanks so much, Sir Samas.
Thank you very much, sir. That's a speech from our chairperson of the Operating Room Global Nigeria chapter investment. We are really grateful for having you. We are glad for having you. So please, let's move on to the WhatsApp for what's it called? For question and answer, contribution, and any other thing. So thank you very much. So the Zoom will be ending soon. Thank you.